This conference will now be recorded.
This is John, and this is AnCan's high-risk recurrent prostate cancer discussion group. It's June 25th, and we're going to get started in just a few minutes. I want to start by acknowledging some of our sponsors, and my list at the present time is Bayer, J&J, Myriad Genetics, Telix, Blue Earth Diagnostics, and Foundation Medicine. We don't push their products. We don't have to.
Where is
But we're
Myriad?
grateful to them for keeping us going. I'm going to start by introducing a new guy. It's Philip Yorston. How old are you, Philip? Can you unmute yourself, Phil?
83 next month.
82. So Phil is an 82-year-old man from Florida. And you were just diagnosed in 2024?
Yes, the diagnosis, I guess, started in May, and now I'm to June. I've gone through MRIs, biopsies, and PSMA.
Oh, you did have a biopsy. What was that? What kind of findings did your biopsy have?
That's when they told me I needed to get a bone scan. They did 12, I think, and that's when he decided there was some outside of the prostate that I needed to go on and get more information. And I think that's where they come up with the Gleason of 9.
Gleason 9? 4 plus 5
Yes,
equals 9?
Yes, sir.
Okay. And it was a regular old prostate adenocarcinoma.
Wow.
There
I don't know.
are a few very strange ones that come up every now and then, and we have to.
Strange ones. Okay. I'd have to look and see the report of the biopsy. You guys are so far fast ahead of me. I'm just trying to catch up. Let's see. Where did I keep that piece of paper? Sorry.
Okay. It could
All
be
right.
an important distinction.
Kept all that. Well, I've got a stack of it here, so I'll find that one.
Okay. You can
I know
poke around as we talk or as other guys
Okay.
talk later on. I just want to make
Okay.
sure that you have what most of us have. And I understand that you have, you're kind of lucky in a way. Most of us in this room, that we didn't have PET scans available to help with diagnosis and staging at the very beginning of our treatment. But you've already had PSMA PET scans. And from what I understand, you have several tumor foci in your prostate, a little bit of invasion outside the prostate capsule up against the rectum, and at least 3 pelvic lymph nodes that look like they're positive, and possibly a metastasis in your right leg bone.
Yes, sir.
Okay. So that puts you in, I guess, what we'd call a very high risk but low volume category. Have you had genetic testing?
Pardon?
Genetic testing of any
Excuse-
sort?
No.
No? Okay.
No, sir.
It might be a good idea for you. Do you have any family history of cancer?
Cancer. Yes, my mother.
What kind of cancer?
Uterine cancer. She died in her 30s.
Wow. Okay. It might be a good idea for you to get testing of the genes that are in all your cells, what we call a germline test to make sure that there aren't any abnormalities or mutations in your family genes. And it might be also a good idea for you to get the cancer samples that they took out of you in the biopsy also tested, because cancer sometimes has its own genes and its own mutations. And nowadays, enough is known about all these genes that it could influence the course of treatment. So when you do get around to finding a genitourinary medical oncologist, if they don't bring it up for you, which I think they will, maybe you could bring up getting some genetic testing.
Okay, out of biopsy and everything. Okay. Yes, I'm going to call another oncologist tomorrow.
Who are you gonna call up?
I'm going to call up. I talked to several people in Schwartzner or whatever is Benjamin, but I think I've heard from you and a couple others that I need to call Bayless in Miami. I think that's
Oh,
his
okay.
first name. They say at the
Belu-
Sylvester Cancer Center.
yeah, Belusic. So we're you're lucky tonight because we've got one guy who's a patient of Dr. Of Abraham. What's his last name? I always forget. Schwartzen. What is it? Paul Freda.
Well, it's Schwarzenberg, I think. I have it here somewhere.
Schwarzenberg. Yeah.
Out of Tampa
Hello.
General.
Yes. So we've got one patient of Dr. Schwarzenberg, and we've got one patient of Dr. Belusic here. So when we open this discussion up shortly, we can ask them for their opinion. This gentleman lives in Vero Beach, Paul Freda. He's a neighbor of yours. But if it were me, probably, I think Dr. Schwarzenberg is very good, and he's given great care to Paul over the years. But I think my preference would be Dr. Belusic, but both of them are good. So back to you, Dr. John, and when we open it up, we can get an opinion from Dr. Jack, an opinion from Paul Freda to help out Phil Yorston.
Okay.
Thank you.
So the first, there's one more bit of information that's kind of interesting. You've been started on Casedex.
I just picked it up today, and I think someone was telling me that and I don't know how to go about it, try and go to this OrgoVox, but I don't know how to switch it when I've just gotten a prescription I picked up here in New Mexico.
Okay, we'll fill you in on all that. So they're probably planning on starting you on Lupron in next week or something like that. Okay, yeah, we'll
Yes, sir.
tell you the pros and cons about Lupron versus Orgovix. It seems like the very first most important thing that you're facing now, unless there's something I don't know about, is finding yourself a good doc.
Yes, sir.
And you're hot on the scent of Dr. Belusic, who we like, and the other guy Paul will tell you about. And then the second thing is how is your treatment going to start? I think you accept that you are going to have to be started on some treatment, right?
Yes, sir. I've come to that from all my friends that are on some treatment, and my new
Okay.
family here.
Okay. Okay. I think we got the history down unless somebody can come up with some more questions. So I'll just open it up and have the guys start helping you out with those two primary questions.
Well, what kind of PSA level did he have?
14.
Okay.
And what we
It went
probably
4,
don't
8,
know,
14.
What?
I started at 4, and when it jumped to 8, that's when we went and then took the other one, the special blood test, whatever, and that's when it jumped up to like 14, I think.
How long did it take to go from 8 to 14?
30 days, 60 days, 30, 60
Okay.
something. It was short.
Yeah.
And what Gleason score did they give you, Phil? You didn't tell us that in your email.
It sounded like 9. I think that's what it is. I had it somewhere. I believe it was 9.
Was that a 4+5 or a 5+4?
Oh boy, I'm going to find that out. 4
That
plus
there's
5. I
Yeah,
think
there's
it
a
was 4 plus 5, but
right, which is the better. You're better off with a 4-5 than you are with a 5-4.
Recorded.
okay.
How is all this going emotionally, by the way? How is going emotionally, by the way?
Well, with Don and another friend of mine that is a has it. I'm feeling better than I was a month ago. I just realized I have to deal with it. Most everybody seems to have been around for 3 or 4 years, and that's good news.
Yeah, yeah, you're not going to die tomorrow. Right, right. They probably didn't bother to tell you that.
Well, my my primary internist, he said, chances are this isn't what's going to kill you, but you need to get going on it now.
Yes. Okay, good. So the initial panic is subsiding. You've got some friends that also have
Yes, sir.
prostate cancer. Okay.
Yes,
That
about
was the
6 of my
first thing
friends.
I reached. When I got diagnosed, the first thing I reached for with other people was cancer. That's what got me through it.
So,
Go
John,
ahead, Rick.
I'd like to suggest that since the best thing that we can be doing for Phil right now is to guide him to a doctor. I'd
Yeah.
like to give Dr. Jack and Paul a chance to speak. And then I see some people have their hands up. We'll definitely come to you momentarily. And I would say, just because Phil's almost 83, it would be a good thing maybe to start with Dr. Jack, since he sees Dr. Belusic, and he's been. It's a very different situation to Dr. Jack, whose disease took years and years and years to develop. He wasn't de novo metastatic, but Dr. Jack, would you like to say a few words to Phil and maybe talk a little bit about Belusic?
Hi, Phil. I've been working with Belusic now for perhaps a year and a half. He's terrific. I think I have some comparison, and I think he is not only bright, he's kind, he's considerate, he pays attention, he gives you as much time as you need, and I like him a lot, and I highly endorse him. And if you can get an appointment to see him, I think we'll be very grateful. I mean,
Thank
I'll
you.
answer any questions you want, but that's overall what I feel about Dr. Belusic.
No, Don says the same thing, Don Rogers. So it's the guiding path that seems to be, and I get to go to Versailles for lunch.
Why not?
Chances
That's an
are,
aside. That's an aside for someone who's been to Miami.
you'll probably have, if it's a long drive, you probably are going to have to. Most of us see our oncologists about 4 times a year. Now, when we
That's
go
okay.
to, if we have chemotherapy or radiation therapy, it's a different story. But for our basic office visits, and my particular guy, they'll do half of those visits, video visits. So just to give you an idea of how often you're going to have to drive there.
He's very flexible with telehealth if you need to see him that way after you see him in person.
Great.
And yeah, my apologies to Don. I forgot that we got you with Belusic as well now. So I'm sorry, I missed that one. Maybe all of you guys can get together for lunch. He's got to go. Well, no, he doesn't have to go past Dr. Jack. Dr. Jack's on the other side, on the south side, but he's got to go past you, Don. How about Paul? Would you like to say something about Dr. Schwartzberg? Because I know you've been with him a long time and you like him.
Oh yeah, I have been with Dr. Schwartzberg for 9 years now, and he's excellent. He's very bright. He has a wonderful manner. He's always given me what I feel is very good advice. He clearly studies my sheet before he comes in to speak with me, and I give him the highest recommendation as a medical oncologist.
And you're close to Vero Beach, aren't you? Where are you?
Vero Beach is an hour and a half from me.
Oh,
Yeah,
okay,
it's an hour and a half north.
okay.
I could also mention another doctor that I recently met at the Proton Therapy Center in Del Rey. His name was Jim Snyder, and he was also excellent. He was honest. He was thorough. He had a wonderful manner. But unfortunately, he's leaving the Del Rey Proton Center, but I'm not sure where he's going. But wherever he's going, if you encountered Jim Snyder, I can highly recommend him also.
Well, what sort of doctor is he? Is he a radiation oncologist or is he a genitourinary medical oncologist?
No, he's a radiation oncologist at the Proton Therapy Center.
Okay. Well, right now, what we're looking for is a GU med onc.
Yeah. Okay. All right. Well, I just thought my experience there, but yeah, I don't know this Belusic at all.
How about Jeff? You have your hand up. Marky, Jeff. Can't hear you, Jeff.
Hello?
There you are.
Phil, when you had your biopsy, how many of the cores had cancer?
I don't know the number, but it seemed like it was enough to make the urologist nervous. So it was like he took 12, and for some number that number didn't seem important to me because I didn't know better. I'm going to go back and look at that. I'll be
Have
more
they talked
informed.
to you about radiation at all?
Well, my notes for that, I did keep notes of the meeting, and the meetings were, I don't think he said age, but he said surgery didn't seem like that was up, and he said radiation looks like sometime in the future, and then he said the Casedex to start with, and then he said he was worried about the bones and how was I feeling with the bones, and I said so far it seems okay. So that's that. I mean, the bones was worrying him the most. I think seems like.
Do you remember where he said in the bones where the metastasis
Right.
were?
I have it from the PSMA. I have a item here. Let's see. It's
On
easy
the
for me to
femur,
refer
Jeff.
to it. Femur. Okay.
Yeah.
That's in the impressions, right?
Right. He has bone metastasis at the in the humeral neck, right at the top of the femur, Jeff Marchi. So probably the treatment path that would be typical would be most likely. I mean, you have 4 or 5 spots, and probably taking age into consideration, probably 2 different types of hormone therapy. Initially, see how you do, and then at some point in the future to debulk the primary with radiation, which would be the standard of care that I would expect either a Schwartzberg or a Belusic to recommend. The reason we suggested the Orgovix to you in writing is because it is a better drug than the Lupron. It doesn't require Casodex first, which the Lupron would do. And it's going to reduce your testosterone quicker. And when you come off it, it's going to restore your testosterone. Now, one thing that is probably why Jim Marshall has his hand up, so I'm going to steal his thunder.
Okay.
You should get your testosterone tested before you start any drugs, so you have a baseline. So you want to ask for a testosterone test as soon as possible, and that way we know where you were before you started any treatment. And they don't suggest, a lot of docs don't suggest that.
Okay, I'll add that in. 3.
That's
Was it-
before
was
you
that it,
start
Jim Marshall?
Casodex.
Jim
Okay.
Marshall, was that it? Was that what you were going to bring up?
One of them.
Okay. What's the other one?
Number 2, are you a veteran, sir?
No, sir.
Okay. Thank you very much.
Jeff, were you trying to say something else too?
Just that he should make sure that he doesn't start Casodex before he gets the testosterone test.
Really? Okay. Where do I go to
Sometimes
get a
it's matter
testosterone?
of-
Just a normal blood test.
Yeah. Yeah, your primary care can even
Okay.
do it. You could just ask for a blood test. And I was wondering
So
why
hold
they
off.
were.
So hold off on the Casodex.
Yeah, maybe a couple
Okay.
days until you get your testosterone drawn, because the Casodex will change it, like Jeff says.
I mean, I would really say hold off on the Casodex. And who is it that's prescribed the Casodex? Was it your urologist?
Yes.
Well, I might go back to him as soon as possible. Did you? Are you in Florida right now, or are you out of town?
No, I'm out of town, but I can go to Quest if I get a script.
Right. I thought I heard you say you were out of town before. That's why I asked you. I would call your urologist and tell him that you would prefer to use Orgovix, and see
Okay.
if he can get that for you right away. Because if he can get you the Orgovix prescription, and I think most of the gents in this room who are using Orgovix are happier using the Orgovix than they were getting an injection. And the Orgovix is a pill, but it does the same thing as the injection. Then you don't need the Casodex.
Okay. But still call
So-
and get a script right away.
So
Testosterone
now
script.
the
you can get
Orgovix
it,
is
there's
a expensive drug,
Yes.
and it's a specialty drug, but it all depends. What type of who's your supplementary with on Medicare?
ARP United. ARP United.
Okay, so it's a United Healthcare. It's a United
Yes, sir.
Healthcare. And do you have a good plan D on that?
No, I don't think my Plan D is so hot. It had a high deductible, but they said this is new to them, so I'm going to have to call and find out about it.
So, it's going to depend on your plan D whether you'll get the Orgovix or not. If you don't get it, there are docs sort of like Belusich, for example, who have ways and means of getting these drugs for you, and I don't really know how they do it. But, your urologist is probably going to get turned down. Somebody like a Belusich may not get turned down. But if you start on the Casodex plus the Lupron, it ain't the end of the world. And the other thing is, don't let them give you a 6-month depot. If he's going to give you a shot that lasts 6 months, tell him no, because that's what a lot of these urologists like to do. If he's going to give you a Lupron shot, make sure it's no longer than a 90-day Lupron shot.
Well, I'm hopeful to get in to see Belusevich right away and And he was talking about something else, so maybe he was talking about the Argovex.
Who was talking about something else?
The urologist was saying there's something better than Lupron, and maybe that's what he was going to talk about.
Yeah.
I couldn't.
Yeah,
Ricky?
that's probably what he was talking about. And ask him, see if he can get it for you.
Okay. Okay, I'm staying on it here, making notes. Thank you. You guys are great. Thank you very much.
How
So
did you
Jeremy,
find us? How did you come to us?
Don.
Oh, you're a.
Don is my researcher. My researcher. He
Oh,
knows
you
he
didn't.
knows so much. I've got
Oh,
CDs, I've got copies, I got all kinds of stuff, and now I'm here.
okay.
Phil and I are friends from a long time ago in graduate school, and we've stayed in
Okay.
touch.
Okay. Well, you got a personal coach, so you're in much better shape than most people.
We go back so many years, it's hard to believe. I think we go back 30 years, maybe 35 or 40 years, 40 years at least, somewhere like that.
Jeremy,
You
have
got
your
a.
hand up?
Yeah,
Yes,
hi.
sir.
Can you,
We
everything's
can
working?
hear you.
Okay.
Yes.
So, I had 4+3, diagnosed in 2021, had prostatectomy performed at UCI by Edward Ochio.
Hold on a second. Hold on a second. We'll come to you, but do you have a comment? This is you had your hand up, so we thought you had a comment on.
Oh no. Oh, I'm so sorry. My
That's
apologies.
okay. We'll
No,
come to
no,
you, promise,
no
because I want
comment.
to
No,
hear.
no, no.
Okay.
Thank you.
Go ahead, Dr. John.
What other questions do you have, Phil?
I don't know. I think you've got me enough to go on. My first quest tomorrow is to get with the good doctor in Miami right away and figure out how and when to get there. I'm flying back from here Sunday, so I moved up my date to get out of here and come back and get this going. But I'm only a week out from I think the 13th is when I had the PSMA bone scan, and now I'm jumping on going back after talking to the urologist when he got the report. So I'm going to make phone calls tomorrow and set up my appointment in Miami.
This meeting is usually every week. Next week's an on week, isn't it, Rick?
Yes.
Yeah.
July the
But
1st.
next week it's going to be on Monday, and it's going to be at 8 o'clock Eastern time next Monday. So you could come in, let us know how your phone calls to the doctors went and whether you got a testosterone test yet or not, and then we can bring you right along to the next step in the process. And if you happen
Okay,
to be
thank you very
married,
much. Thanks for all the
if you happen to be
my
married, your
significant other.
spouse is welcome to sit in as well.
Okay, thank you. Thank you, doctor.
Let's see, I got a hand up. Looks like Jeff with a picture today.
I fixed the camera. Yeah. How is your weight now?
Me?
Yes.
Yeah, 260.
Ooh.
Is that
I haven't lost any.
okay? And are you physically, I might have missed this, but do you exercise regularly?
I walk some. Mostly just walking. I should be going back to therapy, and because I went from Florida to here, going back, I haven't done anything except walking, and not
So
a mile.
one thing you have to be careful of, doesn't happen to all of us, is weight gain with these drugs. And the
Right?
weight, it doesn't do us any good. It increases fatigue. It makes it harder to get around. Stamina goes down. So if I could do happened to me over again, I would have spoken to a nutritionist from the get-go, and I would have just tried not to put on any pounds. Unfortunately, I put on 16 pounds, and life is not as fun as it could be because of these ADT and the abiraterone and the steroids. So it's kind of a warning that I didn't know about, and I regret not having been proactive.
Okay. I will do that. I generally can get down to about 240 with just being conscious of it. But as you said before, doctor, I'm doing well emotionally. Probably not because I've been eating.
It would
In
be
fact, I
very
put on
much in
about 10 or 15 pounds since I figured it out.
it would be very much in your long-term best interest if you could walk more and lose some weight.
How tall are you,
Yes,
Phil?
sir.
Are you as big as Don?
Well, I used to be 5'11", but I think I'm 5'10", or maybe shrinking a little bit, but lost about an inch somewhere.
Only an inch, you're lucky.
And check out the upper right part of your screen, Phil, and you see there's a little thing that looks like two square boxes, one superimposed on another.
Yes, sir. Right next to
Click it.
35 of us online.
Yeah, click it. And you'll see that there's an ongoing discussion that goes along on the side. You can put questions in, you can ask questions, you can talk to Don alone if you want, or to everybody. So get familiar with the chat box.
This runs a lot like Zoom.
Yeah,
Yeah, I teach school on Zoom, so I'm familiar with the chats. As long as it's being recorded, I can go back and look.
yeah, and the recordings are on the AnCan website.
That promise said he
Wow.
can get you a free genetic test. If you click on that, it'll take you to a place where you can get a free genetic test.
Okay, I see this. Wow, $10 copay. I'd jump on that.
No, it's free.
Okay. Okay, I'll keep after the drug things. I've had some with arthritis before and they were very expensive unless they injected you. They injected you, they covered it.
Yeah, because Medicare covers injectable drugs, but not pills.
Okay.
Okay, we'll see you
All right, you've
next
got
week
me on
and
a
see
good
how things are
start.
progressing. All right.
Okay.
Could I go to Jim Barnes? I'm looking for his picture here. Where are you, Jim?
Here I am.
Oh, there you are. Okay.
Sorry about that. So it's my turn. I'm up.
Yep.
Okay. So I've been on kind of a wild ride here with my cancer treatment. My cancer has really gotten out of hand. My PSA had skyrocketed to 765, and I went around and talking to Rick. He suggested a couple other docs I had to get second opinions on, and I did. I went up to see Dr. Bantran at Dana-Farber and Dr. Antonarakis at University of Minnesota. And they all pretty much concurred with my doctor here in Pittsburgh that, I ought to start cabazitaxel. I was trying to get into the AMG 509 trial, which is being run by Amgen, but I couldn't get into that, so I'm on cabazitaxel. I took one dose of cabazitaxel and had some pretty adverse effects. My platelet count has dropped really significantly. So we're trying to get my platelet count up because when I went in for my next cabazitaxel treatment, they were worried about giving it to me for safety reasons. And so they put me on this medication, gave me a shot of this medication called Nplate. Technical name is thrombopoietin. protein antagonist. And I was just wondering if anybody had any experience of that or heard of it, or any way to help increase platelet counts so I'd be eligible for more cabazitaxel treatments. And by the way, it was cabazitaxel and carboplatins, which essentially I passed out in my foyer as I was coming in my front door, and I ended up going to the hospital and spending 5 days in ICU and they gave me 5 pints or 5 units of blood, 4 units of plasma, and a unit of platelets. And that made me swell up like a pig. My ankles swelled up and everything else. So I've been a mess. I've been going through a mess. But I was just interested if anybody had any similar experiences. I don't know if anybody in this group is as far along as I am. But it's Nplates is the name of the medication that they injected me with, and that's supposed to make my body produce more platelets so I can handle more treatments.
Anybody been in this situation or on this particular drug? I don't really know it.
I don't know the drug. I do know that when we've seen people dive in their platelet count and certain other blood counts, we've seen them get infusions. And sometimes the infusions have been successful enough to restore them so they continue treatment. How are your blood counts doing right now, Jim, after all the infusions? And how long ago did this happen, and how are you doing right now?
This happened 2 weeks ago, and I actually just came from the hospital, just had blood drawn, so I'll know my up-to-date blood counts tomorrow. But they actually gave me an IV in the ephemeral artery, and so because they had to pump me so much of fluids, and that's right in your crotch. So, and I basically had 6 IVs going in me when I was in ICU, and they were pumping, like I said, five units of blood in me, 4 units of the plasma, and a unit of platelets. I might have the platelets and the plasmas backwards, but does that count as a transfusion?
Yeah. Sounds like a bad day.
It was a bad day, to say the least. But I feel okay. I get a little lightheaded here and there, but just plugging along. So I go in for an appointment next week, and they'll determine whether my platelets are high enough to give me another cabazitaxel treatment. Because the cabazitaxel treatment, I was at like 765 on my PSA, and then I went back and was tested again 2 weeks later. My PSA went down to 550, and then it went down. The next test, it is at 368.
Oh boy, so we're really hoping that you're going to be able to take this drug because you appear to respond to it.
Exactly. Yeah, I was psyched when I heard it went down again at 368, and that was a month after I had the original cabazitaxel treatment.
So you've only had one cabazitaxel treatment so far?
Yes, and it's dropped by 3.5.
Here's one thing that I am thinking of to discuss with Dr. Appelman, and appreciate the comments from our medical guys. I just have to say, Dr. Jeff, that camera that you got working, it seems to have taken you to the same place as General Joel. I can see you and General Joel are in the same place. You're muted, Dr. Jeff. You're muted.
So
You
we
should
live
go.
on the same island,
Oh,
but
you do? Okay.
but,
You
but
live on the same island.
we put a fence
Fortunately,
up.
Julian's moved off the island. Otherwise, there wouldn't have been enough room for everybody. Now, here's the question, Jim. They're giving you cabazitaxel and carboplatin right now, and we understand why. I'm wondering whether what sort of adjustments can be made there. So, for example, lower doses of both, or maybe just trying one versus the other. The cabazitaxel is probably not the bad actor. From what I know, it's more likely it was the platinum that was the bad actor that pushed your blood count down. But one of our medical team, Dr. Jeff or Dr. John or Dr. Jack, what would you say?
Let me add one. Can I add one other thing? After they gave me all the transfusion, the 5 units of blood, 4 units of plasma, and that I actually next time I went and I got weighed, my weight went from 208 to 232. I gained 24 pounds in a matter of weeks, and now it's back down again because they've given me this Lasix type of pills, the diuretic.
Right.
Yeah.
So I've been peeing a lot, but just that was kind of an interesting side effect.
Okay.
They're giving you steroids, any cortical steroids of any kind.
No.
Yeah, I think that's usually a first line of approach before doing all the end plate and the other fancy drugs.
Like a prednisone or something like that?
Yeah. Infusions.
Jeff, you had something on that? And then I'll get to you, Gary.
So one of the bad side effects of carboplatin, and Rick is right, is bone marrow suppression. And most likely that was the bad actor, and it suppressed the production of platelets. How low did your platelets go?
27.
27 period? 27?
27,000.
Oh, 1,000. All right. Wow. Okay.
I mean, but it should be 100,000, right?
Yeah. I mean, 27,000 is a low count.
Yeah.
When you shave, were you bleeding a lot?
No. There was one point I did have a spontaneous bleeding from my lip because I bent over and a drop of blood hit the floor, but that was it. Nothing excessive. But bleeding in I had excessive blood in my stool. Right after I came out of the hospital, that was a mess. And they also found 3 ulcers in my stomach that were bleeding ulcers, and so that was a big mess too. So
I think Rick is right. I think that was your bad actor that clobbered you.
yeah, and he did tell me he hit me with a full dose of the carboplatin and the cabazitaxel. Because
try out Rick's idea about maybe just one drug or lower doses of them.
Yeah, I think that's on Dr. Appleman's mind because he mentioned that I had the full dose of cabazitaxel and carboplatin, and because my blood work was so good going into the treatment.
Yeah. Jim, I forgot, what's your living situation?
Like married and
You live alone, or you live with a wife or family, or?
No, my wife's sleeping on the couch here.
Okay. Yeah. Just wondering about your backup system.
Yeah, thank
Gary,
God.
what do you got?
Thank God I have her.
Yeah.
I'm sorry, what was the
That's
last
what
thing you said, John?
I was going to call on Gary. He has his hand up.
Okay.
Jim, I'm sorry you're going through this, but how many treatments did they talk about, assuming your numbers were okay?
I believe 6. But I've been through so many different treatments.
Yes,
Right,
you sure have.
right.
You know, the threshold for danger is
I think I'm the current record holder for lutetium and actinium combination
Yeah. And travel for treatment too.
and travel, right?
the danger threshold on low platelets is 10,000, and you're at 27,000. I still, it sounds frightening. That I certainly wouldn't want to be there. But when you approach 10,000, that's when the bleeding becomes dangerous. And right now you're not at that, and hopefully you never will be.
Right. That's kind of a death sentence there, right?
10,000 is scary. You got to get transfusions of packed red blood cells.
And my red blood cells and white blood cells counts are okay right now. It's just the platelets that's the problem.
Yeah. And it's the platelets that are keeping your red blood cells in your body. So that's what Jack was talking about. Okay, Jim, for now?
Yeah, I've had enough.
Okay.
But thank you
Frank
for
Babish,
the feedback.
we're glad to hear from you. Frank,
Yes. Um, also, my condition has changed a lot in the last 3 weeks. I started on Pluvicto in March and went through 2 treatments. And at the end of the 2 treatments, my PSA jumped from approximately 3 up to 32. And immediately my GU guy said that the first thing he wanted to do was to get to double check the lab work, and he sent me to another lab to get my PSA drawn, but it confirmed that there was no mistake made. So he then canceled the 3rd treatment of Pluvicto because he said it was very apparent that it wasn't working, and he didn't want to continue with that treatment. I went in to see him. He also ordered another PSMA scan because he was trying to find out what caused the jump in the PSA. And the last PSMA scan I had was middle of February. And in that scan, it just noted my nodules in my lungs, and nothing else showed up except for there. When they ran the PSMA scan last Thursday, they found that the cancer had progressed. It was in the bones now, and this all occurred in a matter of less than 3 months. In the shoulders, in the sacrum, in the femur. The lungs were still pretty stable with the nodules in the lungs. So we had our discussion today, and he's pretty well fixed in on going with a PARP inhibitor, the olaparib, if I'm pronouncing it correctly.
You have BRCA2, don't you, Frank?
Yes, I have BRCA2, and he feels he wrote up a prescription today for 200 milligrams twice a day. He adjusted it down a little bit because of my kidney issues, but he feels that that would be effective, or at least a good chance of being effective. We also discussed a test trial that is the AMG 509, which is the immune therapy that he was talking about. He has a colleague in Pittsburgh that's running a test trial there. I'm not sure where else close by Ohio is also running the AMG 509, but that also, from what he said and from what I've read since the appointment with him this morning, that also seems to be a possibility with the conditions that that have shown up in the last 3 months. So I'm going to be asking if he can find if there is an opening with the AMG 509, and then talk to him about the comparison between the PARP inhibitor and the test trial with the AMG 509.
Wow.
So that's where my condition is at this time. I'm just taking some Tylenol arthritis, and that seems to be working okay on the shoulders and the back. I don't have a great deal of pain from them right now. But I wanted to throw that out with the opinion, if anybody that's familiar with this AMG 509 and what that may bring to the table with what I'm facing.
I think Jim and Rick probably have both things that they'd like to say now. Jim?
Well, I was just going to say the doctor in Pittsburgh is my doctor, Dr. Appleman. He is the principal investigator for the AMG 509 trial. And in reading the introduction and the consent form, which I had, it was a 60-page document. It stated they gave it 97 men in phase 1, and 60 of them saw a significant drop in their PSA, a 50% or greater drop in their PSA.
Where is Dr. Appleton?
At the Hillman Cancer Center, which is part of University of Pittsburgh Medical Center.
Okay, that's the trial that he's talking about. He is a colleague of my GU oncologist, and he's had conversations about it. This morning he said he was going to check. He thought that the test trial may have been closed out, but he was going to check on it to see if there were any openings.
That's what I found. The trial was closed out, and I was unable to participate in it. And I was hoping there were a couple slots left, or a slot might open up for one reason or another. But yet I was still unable to get in the trial.
So you might be sitting behind Jim Barnes, Mr. Fabish.
Now that I've had the cabazitaxel, they say that I've had too many treatments and I'm not eligible for the AMG 509 trial.
So there's a couple of things with 509. One is that, and I wrote this to you, Frank, you probably saw. One is
Yes.
that it's a bispecific and it attaches to something called STEAP. I cannot remember what STEAP stands for, but it's a protein that's expressed on the prostate cancer cell. And so you have to be expressing that protein. So the first thing is to make sure you're expressing that protein. Otherwise, you're not even a starter for that. It's like, think of it like PSMA. Most people express PSMA, but not everybody. And if you don't express PSMA, then you're not suitable for a PSMA treatment. Now, the STEAP is a similar type of protein, and one end of this molecule attaches to the protein, and the other end pulls in T cells from your immune system, and that's how the 509 works in a very simplified form. And I can't even tell you in a more complicated form how it works, but there are people that could if they were. We don't have Ben or Len here, so but that's basically what it is. Now, I happen to think the most important thing for you. Oh, Dr. Jeff put it in. Six-transmembrane epithelial antigen of prostate, STEAP. Thank you, Dr. Jeff. It's in the chat window. STEAP. There you go. Now, I think step one is you've got to get next generation sequencing again, and like immediately. And I would definitely want to do that. I mean, Dr. Mortasavi. Dr. Mortasavi.
Yeah.
Mortasavi is ordering you the PARP inhibitor. We don't know whether you're still expressing the BRCA. And until you know that you're still expressing the BRCA, I wouldn't stick one of those pills in my mouth. Because these mutations, these somatic mutations, they can reverse, especially with treatment. And we've seen it happen. Len had a mutation reverse on him. In fact, I'm just going to take a second to do a very quick promo. Next week, July the 1st, we're starting an hour early. We're going to go through the highlights from ASCO 24, and one of the papers I've picked out is about BRCA, somatic BRCA reversing, because we know at least two people where somatic BRCA is reversed. Actually, one of them was a germline BRCA it reversed, which is amazing. But yes, we know this. So until we know what you're expressing in this age of precision medicine, we got to make sure you're still expressing it. And we can't assume that just because you had a somatic mutation last November that you've got a somatic mutation today. The second thing is there may be other biomarkers that show up. Now, if my notes are correct, you carry P10. From looking back in November on my notes last November, I made a note that you had P10. If, for example, right now, we saw TP53 along with that P10, which we might do, then you might be more of a candidate for a platinum than a PARP inhibitor. But the whole point of this precision medicine is that we do the testing and then we find the best treatment for you. And we have a lot of treatments out there, and there could be trials out there for particular things. Now, if you are still showing the BRCA, I would say, sure, yeah, good idea. So that's why I said to you when I wrote to you earlier on today, call Mordasavi and have him take some blood from you and send it to Tempus or send it to Amgen to FMI immediately.
Yes.
I
I,
actually had
I'll,
I actually had those markers, Rick, that actually qualified me for, made me a candidate for the AMG 509, the PT53 and the RB1 and the P10. And that's why that led me to the next treatment, which was the carboplatin.
Right. Right. I mean, when you've got that trifecta and it's not a good trifecta, as Jim well knows, then you're probably better off with the platinum, and that's why we're getting good responses from Jim with these drugs. Is there anybody on the call right now who had a marker early on in their disease which has since disappeared? Of course, we don't have Len, because I know he definitely had, but anyone had something that's disappeared in between their somatic scans? They got one maybe a year ago and now it's not there. But it does happen. It can happen, as the docs will tell you on here. Joe Blanchette.
Yes, I've taken 2 FMI tests, one tissue and one blood test. They found on the tissue tests P10 and T53. When Dr. E gave me the Tempest test, it found no P10 and very low TP53. So it does change. Yes.
It changes. It changes, and this is why when they approved these tests originally, and forgive me if some of you have heard this before, but they said you could have one test in your lifetime, and we went back to Medicare and we said, no, you've got to allow for testing for these men every 6 to 12 months if they need it, and they changed the rules. And now, if the doctor feels you should be retested, they'll pay for it as many times as you need it. And I'm sure Dr. Mordasavi is aware of people where things have changed, and especially the BRCA. I mean, I've seen it, like I say, seen it a couple of times. The BRCA's what they call wild type, which is normal. Wild type means normal. So please ask him to. And we're tending now more towards Tempest than FMI for a number of reasons. But please get him to send something off ASAP to a blood sample, or probably a blood sample. Probably a blood sample is even better than him certainly better than taking a bone sample. But have him send something off to Tempest. The other thing is, you may be a good candidate right now for an immunotherapy. Maybe your MSI has changed. Maybe your TMB has changed. And they didn't show up before, but they could show up now. So before we plunge into something, let's make sure it's the right thing.
I'll communicate with him tomorrow morning.
Great. Let us know. And I'm sorry, Frank, you had those new mutations.
Thank you.
I'm gonna move to Peter Monaco now.
Hi. I just wanted to give an update. I recently had reported that I was looking at possibly doing some spot radiation to a lymph node in my lower paratracheal area, and that the radiation oncologist was a little bit concerned, given that I'm on blood thinners and getting in there was a little dicey. So he did some research, and I went to see him today, and we decided that I could go ahead. His solution was that he's going to turn down the intensity of the radiation a little bit, so it won't be as heavy a dose. and he's fairly confident that I wouldn't have any bleeding issues, and he still thinks it will be effective in killing off this lymph node, what's in there, at least for a while. And so I'm going to go ahead and do it, probably in mid-September. So that was my update. Last time I reported, I said that I wasn't sure if I was going to do it. I don't know if the oncologist was going to think it was the right thing to do, but that was 3 weeks ago, and I saw him today. And after some discussion, he thought it would be good. And I'm going to do it in 5 consecutive days treatments. I'm not going to space them out. They're in Manhattan, New York City, and I decided to do it all at one time. And again, that should be in around mid-September.
Okay, well, thanks for the update. We were all curious about whether it was going to be safe to go to that spot. You know, as much as other forms of therapy have advanced in the last few years, radiation has really taken off.
Right. It's pretty accurate now. It's much more targeted than it used to be, from what I gather.
Why the decision to wait until September?
That turned out to be like our mutual schedules, myself and the doctor. He didn't think it was going to be, a problem waiting. Do you think it's waiting too long, Rick?
I mean, it seems to me that if you need it and you're going to do it and there's a spot there, you may as well do it as quickly as possible. I don't see, I mean, I can't see any sense in waiting. And what, anyone else's opinion on that?
Do we have any information about the velocity of the prostate cancer, such as PSA doubling time or rapid appearance of new metastases? Does it seem to be running away really fast or just chugging along slowly?
Right now I'm at a 0 PSA. I have been for the last couple of years. I was on Abby and ADT, and my doctor, my oncologist, recently took me off that to kind of give me a break. I'm on Nubeqa only right now, and I just had my first PSA test after 60 days on Nubeqa, and it was still undetectable. Though my
Well, at
testosterone
least
is up to 8, so I'm starting to get some
there's no
testosterone
evidence.
recovery.
At least there's no evidence that it's a runaway train. I think most of us would want to get this done as soon as we conveniently could. But it's reassuring to hear your PSA is negligible.
Yeah, that's been pretty good under treatment. It's been responding to treatment, so I've been fortunate in that department. Yeah, so and the great thing about this this is Mount Sinai in Manhattan, and I live way out in the boondocks in Hackettstown, New Jersey, which is way out there. And I asked about, did they provide any housing or anything? And who knew that the American Cancer Society has the Hope House or something like that. It's basically a little hotel right on 34th Street and Broadway in New York City, and they will give you a room for free. So I'm going to do it. You got to reserve it, and there's a little bit of a waiting time for that. So I'm going to follow up on that and call the doctor and say, let's do it sooner rather than later. And I got to work with their social worker group who gets you hooked up with the room.
Right.
Which is the reason why I want to do it in 5 consecutive rather than do it every other day. Instead, I can do it every day if I want to, and that's what I want to do.
I think we all should be aware of Hope Lodges and other arrangements for if we have to travel for treatment.
Yeah,
Yeah, our
it's
our
magnificent,
expert
really.
our expert is Joel Blanchette on such topics, and AnCan tries to be um, a full service operation, but right now we're not stretching to hotel rooms in New York, I'm afraid. But but that said, um, I know Joel has done a lot of research on this stuff, and he's your man. If Hope Lodge falls through, reach out to Joel. He'll tell you what else is going on. He's
I
he's on
will.
top of
I
it.
will. So that's my update.
Okay, thank you. Jack, can we go to you now?
You say me, John?
Yep, yep.
Oh, okay. So I had this cough and it wasn't going away. So I went on Medrol pack for a week and seemed to subside, and then it came back again. Now I have pulmonary metastasis, so I was concerned. But then since it went away, I wasn't as concerned. But then again, I saw my medical oncologist, Dr. Belusic. I asked him to listen to my lungs, and he heard a wheeze. And but it was in the lower lobe, and my metastasis is in the subcarinal, right below the trachea. So he said, why don't you go see the pulmonologist, the one who did the endobronchial ultrasound biopsy and diagnosed my adenocarcinoma after 21 years post-prostatectomy. So I went to see him, and he listened. He couldn't hear anything. And then he ordered pulmonary function studies and something called a bronchial challenge and a CT scan with no contrast. First scan I've had since I had my PSMA scan, my accident scan, all my scans. And although in the past they've ordered plain scans without anything too, and they didn't see much of anything, this time the CT scan didn't show anything at all that was of concern. He looked at the subcarinal lymph node area where the cancer was, and he saw the little lymph nodes, and he said, look like normal lymph nodes. I don't know if they have cancer, whether they're active or not. I said, is there any way of determining whether or not, because I had SBRT 5 days in a row, as you just mentioned, and I didn't know whether or not that had an effect on killing the tissue or whether or not it's still active. He said, we cannot tell that. I asked my radiation oncologist at some point, how can you tell whether or not it's active or not? He said, we can't really. He said, I said, what about if I get another FDG scan or an SBRT, or a PSMA or an Axum scan? He said, let's not do that yet because you've only had the SBRT a little over a year ago. And he said, you could have some coding, PSMA, as you mentioned many times, may still be around there, even though it's dead tissue. He said, and it may frighten you and get anxious. I've seen people get anxious unnecessarily. So therefore, I think we should wait a while before we do a repeat PSMA or an Axum or even an FDG. And let's, see what happens with your PSA. And my PSA, fortunately, over a year of treatment, doublet therapy is still fortunately undetectable. So I just wanted to get a little feedback from you guys about plain CT scans and how diagnostic are they, or what value have you had in your experience when you have pulmonary or bone metastasis? Because my rib metastasis didn't show up either. He said, I don't see anything on your left posterior lateral rib. He couldn't see my lumbar spine. It wasn't in the field of the chest CT scan. So I wonder if I can get a little feedback from you guys about that.
The only thought that crosses my mind is how long it took my brother's radiation therapy. It was still reducing his PSA after a whole year and a half. The benefit was delayed by a long time, and then he was still so the idea that the radiation therapy could be sort of still doing its job, or they could be some remnants of PSMA around, I guess that sounds possible. He also invited you to say you were too anxious to wait, and you didn't take him up on it, right?
Who invited me to say I'm too anxious to wait? I didn't get that. You talking to me?
Yeah. I thought he said that that you don't really need
Oh,
to
no,
be.
he said if you get the PSMA scan now, it may generate anxiety in you if you end up showing PSMA avidity, because
Oh, yeah, okay, I see.
it may be a false positive.
The false
because
positive that will
the
drive you crazy, yeah.
radiation may have worked, but it's still showing up as PSMA avid, when in reality it's necrotic tissue. And it's,
Gotcha.
so that's what he said.
I understand. Any comments or suggestions for Jack?
Yeah, there's nothing about that. The other thing is the lability of my absolute neutrophils. I was feeling reassured 2 months ago. It went up. My absolute neutrophils went up to 2.82, and now it's back down to 1.62. And I said, oh, And he says the darolutamide does that. I see in all my patients. It's very labile, up and down, up and down. He said, don't expect it to be exponentially rising and going back to normal so soon. As long as you stay on that darolutamide, it's going to be a lot of volatility there. So have you all experienced that too, darolutamide, doing that?
I did. I don't know if I got down to 1.62, but there was quite a bit of variability. I mean, I just put it off to getting exposed to infections and throwing them off and all that stuff. But
I had a bad bronchitis.
if you've got 1,500 neutrophils or more, you're safe, right? You're perfectly safe.
Yeah. No, they're not concerned. I just didn't understand why it doesn't keep going. And the other thing I wanted to mention is the metformin that I'm taking prophylactically to prevent, the prediabetes. I don't have it. My PSA, my FBS usually runs 85 or so. It's jumped up to 100, and it stays pretty much around 100 since I've been on doublet therapy. And there's not much I can do about it, even metformin 500 twice a day. I don't feel like going to 1,000 twice a day like some people have. So I'm going to stick with, if it sticks around 100 or 101, 102, I'll just, tough it out and hope I don't get pre-diabetic. You guys experience that with metformin?
I'm on metformin. I would be comfortable with that, what you said. The more you push the dose, more you might have a side effect.
I'm just trying to do every prophylactic thing possible to prevent diabetes and cardiovascular.
Yeah, I mean, there was another paper that came out on metformin that said that it didn't really have an impact, and we don't have our anti-metformin campaigner on the call tonight, Len, otherwise known as Len Sierra, because he'd be telling you why bother. I think most of the guys that use it are on 1,000, unless that gives them issues and gut issues, because some people can't tolerate that much, and then they cut back to 500. How many people are on metformin? Oh, we got a few. And how many people are taking 500? Okay, anybody taking 500 other than Jack? Bob is, and Larry Fish is, and who's taking 1,000? Anybody? One, no. Well, Larry's taking 1,000, and everybody else is taking 500. So,
what's your fasting blood sugar, Larry?
I'm diabetic,
Oh,
130.
all right, that makes sense.
I'm also on other meds. I'm taking metformin morning and night, 500, 500, but I'm thinking of cutting it to 250, 250.
All
Are you
right, I got
diabetic
about
as
a
a
half a
result of the?
dozen guys coming up, plus whoever of the late guys might need time. So I'm going
All
to
right,
move on to Jerry Pelfrey.
all right, thank you.
Okay.
Okay, just a quick update. I had my SBRT on L4 about 2.5 months ago. Now that I'm on Nubeqa and Orgovyx, I have actually been undetectable for the last 2 months. I'll find out about the third month here next week. So I'm doing quite well. And then Dr. E wanted me to still have a PSMA scan. So I had that 2 weeks ago. And she only said it was because of she wanted staging. So nothing showed up on the PSMA. Everything was fine, supposedly. And that's the update. That's where I'm at. My question is on venlafaxine. Is anyone else taking venlafaxine or
I
Epoxy?
am. I've been taking venlafaxine since 2000.
Okay, here's my question. When I was working out with my treadmill, my heart rate, I could get up to 130, 140. And then my knees kind of were giving me trouble, so I went and got a recumbent bike. And I cannot get my heart rate on that recumbent bike past 100. As a matter of fact, I can hardly get it up to 100. It usually runs between 85 and 95. And a doc told me that it could be the venlafaxine. But everything I've read about venlafaxine says, if anything, it would increase your heart rate. Have you found that, Rick, at all?
I mean, I have never had a problem getting my heart rate up, and I don't think the venlafaxine had any impact on my heart rate. That, that's what I would say.
Yeah.
I would send a message. I'd send a message to Dr. E, and ask her, because she's an internist. She's a medical oncologist, but she's trained as an internist.
Yeah.
And ask her what she thinks. But I wouldn't be blaming it on the venlafaxine. Are you just out of curiosity? Are you taking extended release, or are you taking it all in one go?
No, it's extended release, 225 ER.
Okay. Well, I take a lot less than that. I take 100 and
12 and
110,
a
I think,
half.
or 111. 337.5. What's that? 111.5, I think. I take 337.5s extended release. The other thing is, and I've done this before, Jerry, you can play around with the dose. You can try slightly lower dose and see if it helps you and how that impacts your mood, and if you might be able to manage with less, and so that's another thing to consider.
Yeah.
Gary.
Thanks, Rick. Jerry, if you have an undetectable PSA, what was Dr. E's reason for ordering the PSA?
On her
I'm sorry,
request,
it's a PSM.
on her request, all it was staging.
Staging?
Yep.
What
I can't.
what was
That's
the
all I
type
can
of
say.
exercise? I'm sorry, Jerry.
What?
What was the type of exercise that got you the higher heart rate?
Treadmill. Walking on the treadmill.
Why don't you test it out by jumping back on the treadmill and see what happens?
Good idea.
All right.
Maybe the recumbent bike is just not able to do it for you.
Are you
Yeah,
taking
the other
Jerry?
thing is, maybe you got to work harder on that recumbent bike. I mean, you're lying down, and I see people on there, and they're moving their legs so slowly, and you don't get your heart rate up. You got to work whatever you're doing. You got to work at it, and you may have been working harder on the treadmill than you are on the recumbent bike.
Well, on the recumbent bike, they wanted me to start out at 1 and 2. I'm already up to 7, and there's only 8 and 9 left. And I'm going at about 9.5 to 10 miles an hour right now. So
What were you doing on the treadmill?
What's your cadence? How many per minute? How many pedals per minute? That's what you got to look at. Don't look at the 10 miles an hour. You want to look at how fast those legs are moving. If you want to get those legs like spinning round, and try and get it up towards 70 to 80. If you're doing it at 40 to 50, it's not going to affect your heart. It's not the resistance, it's how quickly you're
pedaling.
going around.
Yeah.
I want to keep moving because we're going to run out of time, but I want to see Dr.
Jack
Jeffs.
had a
Maybe he's probably going to ask you about what other meds you're on. I don't know.
Yeah,
Jeff?
that's one. Yes, so what other meds are you on?
The only other meds I'm on are my blood pressure and cholesterol. Cholesterol is Brovicol, and blood and let's see, I'm on Candesartan, and my cardiologist also added. I never can say this correctly. I can't pull it out right now. It's
Do you take any beta blockers?
no.
So what's the highest? So your heart rate on this in your life? What's the highest you can get it to go?
Right now?
Yep.
When I'm pumping as hard as I can, it gets up to like 101.
How old are you?
78.
So what's wrong with 101? That's a pretty good. What are you trying to do? How high do you think you're supposed to go?
About 120. I weigh 170. If you take 80% of that.
No, it's 220 minus your age, then 80%.
Well, that's approximately almost 80 minus 220. That's 140.
That would be your maximum.
Yeah.
So
when people
exercising anything over 100 is probably good enough to get a cardiovascular workout.
Yeah, and in fact, you're running a risk of an arrhythmia if you push too hard. I wouldn't, I've been using Effexor with my patients for years, and if anything, it can cause an arrhythmia, and it can cause the heart to get a tachycardia, QTc, prolongation, a lot of things that are kind of risky. What are you doing? You're doing it for hot flashes? Is that why you're taking it?
No, it was mood.
What?
I've been taking it. It
your
was
mood?
my mood
Okay.
changes and all that.
Okay.
So I really think Rick's probably got a good suggestion, and so does Dr. John. I'll reduce the dosage and see if that helps, and also try the treadmill again, and just to see. I can put my knee supports back on and go on the treadmill and see. So thank you.
And cycle on that recliner to cadence. You want to be cycling to cadence, not to speed.
Yeah,
And you
but
want
I
to
don't
get
know
that
how I can.
cadence.
How do you calculate cadence when they only
It's
give you
on there.
this?
It'll measure it for you on your bike. It should measure it
No,
for you on your bike. It'll tell you RPM. Doesn't it tell you RPM?
no. Well, yeah, I do about my RPM is about 9.5 to 10 miles an hour.
No, that's speed. RPM is how quickly your feet are moving.
It doesn't
Are you
have
sure?
RPM on it.
It does. It says 80, 85, 70,
I'm
75.
sure it does. They
There's a
all
big
do.
difference between going 75, 80 versus 65 or 60.
Yeah.
So you
I'm
want to
gonna
put,
I'm gonna step in here, guys. Get a
Go
last
ahead.
comment from Richard Fisk quickly, and then I'm gonna head down the list. I don't want to leave anyone out.
Yeah, just a
I'm
quick
done.
thought. I had to
Thank
get
you.
off the treadmill because of my joints. I went to an elliptical, and it's easier to get the heart rate up because you're still carrying your weight on your feet instead of sitting down, but it's much easier on the joints. You've got the same motion as you have on the recumbent, but you're carrying your weight rather than sitting on an elliptical.
Yeah, good suggestion. Like a standing desk instead of a sitting one. Steve, still here? Steve L.
Yes, thank you. Yes, I am having my second Provenge infusion this week. The first one, I reacted to the infusion substantially, had sort of, after it was almost done, had extreme back pain on both sides pulsating, and they had to stop the infusion. Was wondering if there's anyone around now with any Provenge experience or thoughts of how to minimize the side effect of the infusion.
Who do we got?
Spoke
Oh,
to a guy
really? We have
last
a whole
week and he
we
had
have a
both
whole
side
room with
effects.
no Provenge people. Rick, we're going to have to rely on your memory for people that have been on Provenge in the past.
Yeah, Geoffrey will get to you, believe me. But this is what happens when people post in the chat window, and I was looking at that, and I
Sorry.
missed Steve. Sorry.
He's having some problems with Provenge, particularly back pain, and we don't have any guys here that have
hey
been
guys,
on it.
I want to check. I've got to move.
Sorry, what were you saying? Somebody just wanted to make a point there.
That was
As far
Ken.
as
Ken?
Provenge, go ahead, Ken.
I'm just letting you all know I've got to move on to something else. No, I'm moving on to something else. I've enjoyed listening. You all have a good evening.
Well, I'm sorry we didn't get to you, Ken. If you could hold the question till next week.
Oh, it's not a problem.
Okay.
Okay. Good night.
Okay, sorry.
And there's no meeting after this, so we can continue. There's no longer a MS meeting that follows this. We've moved that to earlier in the day today. So let's see. What we've seen mostly is sort of fluish symptoms around the time of the Provenge, and even some people passing out because they get dehydrated, and we need to be sure they're very well hydrated whilst they're both going through the extraction and when they put it back in. What do they call it when they take it out? What's the medical term for when they take it out, Dr. John?
extraction or something, or pheresis?
Yeah.
Pheresis, leukapheresis. Thank you.
Pheresis?
The leukapheresis. So, did you stay hydrated, Steve, during the leukapheresis?
Yes, I stayed well hydrated during the leukapheresis and didn't have any trouble then. During the infusion, I may not have been quite as concerned about the um, staying hydrated. I'm certainly going to this time, and I think they plan to run the infusion a little slower also.
Yeah, that's and what were your side effects from the infusion?
When
Back pain.
it was about 80% done, I developed some really severe pulsating lower back pain that,
Okay.
yeah.
And did it persist? Did it persist afterwards?
Yeah, they had to shut down the infusion and they shut it down for about a half hour. Um, and the pain subsided and then they started it up again. And right as they ended, the pain came back somewhat.
And then what about the next day?
Uh, they gave me some pain meds that unfortunately knocked down my blood pressure to 70 systolic, and so they kept me there another hour and a half or so, and the pain diminished, and it the I was sort of exhausted from the experience and a little, but the pain was gone.
Okay, so
Here's a surprise. Excuse me, Rick, that I just looked up. It gave a 29.6% incident of back pain with Provenge. Damn. Rick, I interrupted you. What were you going to say?
no, I mean, I think this is all around the infusion. It's nothing that persists, and they just have to manage the reinfusion better. And we've seen this where people haven't done well the first time, but they've adjusted during that, and then they do fine for the last two.
That's good to hear. I'm not looking forward to the pain again, that's for sure, but I'm sort of committed to doing it.
Right. Well, you shouldn't have pain again because they should slow it down. Just remind them when they reinfuse next time, just remind them you've got to, take it slowly.
All right. I will do that. Thank you.
Okay, Steve. Next, I got Jeremy. Do you want to catch us up on 3 years?
Hi guys. Hi Rick.
Hi.
I miss Len, so Len's not here today.
Yeah.
Len is on his way down to Florida because his family is going there for July 4th. So
Okay.
it's not exactly the time to go to Florida, but that's where Len is. But I'll tell him that you were here.
Okay. Well, I had held off, I got diagnosed with prostate cancer 4+3 at the tail end of the pandemic. Had prostatectomy RP done in combination with hernia surgery, 14 hours because they did find some cancer outside, and they kept resecting till they got negative margins. 2.5 years of undetectable PSA, and then it ticked up to 0.1, and then about 3 months ago it ticked up to 0.13, and about a month ago it was like 0.16. So had a PET scan done with a contrast material called Persloma or something like that.
Ilarify?
Persloma. It's a contrast material. It was, I guess, developed in conjunction with my surgeon, Edward Uccio, over at UC Irvine, and it came back negative. So the recommendation from the radiology was to get a multiphasic MRI, but I just sent a note to Uccio and said, you don't need that, but we should have you come in a week and talk about radiation and hormone therapy. So I've actually been considering, I spoke with a friend of mine. He's actually the chairman over at City of Hope. He said, you got to come and see our guys over here. And so I was thinking that maybe I need to go to City of Hope and see what they say.
Yeah. Well, I'd say a couple of things. The first thing you need is a PSMA scan.
Yeah.
And I'm not fully sure what scan Posluma. Oh, wait a minute. Posluma is a PSMA scan, I think.
It is. It's still a PET scan. Yeah, with this contrasting material that targets the PSA.
Yes,
at
Posluma.
Low levels. Yeah.
I can't remember who makes Posluma. It's another one. It's not Telix. It's the third one. Oh, I know who makes it. One of our sponsors. It's that's the Blue Earth. That's the blue. Posluma is the Blue Earth one. Okay.
Yes.
That it's made by Blue Earth, Posluma. And what did they say on the Posluma? Nothing showed.
Nothing showed.
Okay. Well, one thing is to get that reread by, and definitely City of Hope's a great hospital.
Okay.
There's a number of decent docs over there.
Rick, you actually referred a friend of mine to UCLA, and his initial PET scan was also negative, and then they reread it, and there was, I guess, a little something. So he ended up getting the SBRT 5 days. He opted out of the ADT. That was his choice. So I could also go to UCLA, I suppose, to the same doctor you referred him to.
Yeah, he's very good, Rettig. I mean, he's
yes.
great. Yeah, I mean, you know, at City of Hope, Tanya Dorf is terrific. And then there's another guy whose name I cannot remember. I just have to look it up. Who's also very good. Rettig is great. And Herb, where's Herb Courtney? How do you like Dr. Rettig, Herb?
Yeah, I was just going to jump in and say, yeah, you can't go wrong with Rettig. He's just really on top of everything. I've been with him now for best over a year, and yeah, he's great. Because I start out with your situation, radical prostatectomy, undetectable PSA for about 2 years, 2.5 years. Then it started creeping up, and then I started out on hormone with Casodex or bicalutamide, and anyway, ended up with Rettig and couldn't be happier. I'm doing fine on Nubeqa.
Oh, with Rettig, is Rettig a Uro-onc or Rad-onc or?
He's a GU med-onc, yeah.
GU med-onc. So you haven't done the radiation then? You just went the.
No, I've never done any radiation because, well, all my PSMA PET scans have been negative, and we purposely let my PSA go as high as 7, and I've had PSMA PET scans and MRIs, and everything's negative. So, my cancer is not expressing PSMA, but there's no indication that it's gone anywhere. And it responds great to the Nubeqa.
Oh, so you can actually have this terminology, non-expressive PSA,
PSMA.
PSMA means your PSA could be up, but the cancer can't be detected using PSMA.
That's
Right.
correct.
You may not express PSMA. About somewhere between 10 and 20% of men do not express PSMA. So just because your PSMA doesn't show anything, but the problem is it's very difficult. We can't really test to see if you express PSMA or not. So it's very hard to determine if you don't express PSMA.
Okay.
But what we're I think our point is that if the cancer comes back, the starting point should be with a genitourinary medical oncologist.
Okay.
And then let them direct you, as opposed to starting with a radiation oncologist.
Right.
And then when
Because
they can't handle it anymore, they pass you on. We would rather see you start with a GU medical oncologist. The other guy I was thinking of at City of Hope is Powell, Dr. Powell, P-A-L. He's also real good. But that's, what we would do is direct you to a GU medical oncologist, and then you and them together decide what type of treatment you might need.
How about these
because
guys in
if you're
Marina
not
Del
if you're
Rey?
not if you're not expressing PSMA, where would you radiate? I mean,
Right. No
Well,
target.
the I guess from what I understand is the prostate bed.
Yeah, but you see, there's a
But
couple
you're
of
flying
things.
blind, right? Basically.
You're flying blind, and in the old days, before PSMA scans, well, that isn't such old, but pre-PSMA, they would radiate. They would radiate either the prostate bed, or they do what's called rabbit ears, which is the prostate bed and sort of two channels going up on the left and the right. We always feel that if you're going to radiate the whole pelvic girdle, which is the conservative way to go and likely to get everything. So I would never, if it were me, I'd never go in and get just the prostate bed. Because if it's in the prostate bed, it's gotten out. And if it's gotten out, it could be somewhere else. And what we see is people that only radiate the prostate bed, it comes back a little bit later. Now, with PSMA technology, we're able to see, we hope, where it is. So we can be more focused on where we're radiating. Although by and large, they're still going to do one of these three patterns: the prostate bed, the rabbit ears, or the whole pelvic girdle. But that, to me, is a discussion that's worth having with a GU medical oncologist rather than a radiation oncologist, because the radiation oncologist here is the technician and not the quarterback.
And how about the multi?
And then they would refer you at that point to a radiation oncologist to get your treatment.
And how about the multiphasic MRI and additional genetic testing?
Well, I mean, I don't see the benefit. I don't know. There are some doctors we love and respect who really like these full body MRIs. So I don't really have a strong opinion, but yes, there are doctors who want to do full body MRIs. I would say in your situation where it's just beginning to creep up, 0.15, 0.16, I would probably, I don't know. It wouldn't be the first thing that comes to my mind. I mean, what would come to my mind is to get myself to a GU med onc, and then maybe to wait and to do another PSMA scan when I'm at 0.25 or 0.3 and see if I can see anything then. If it continues to be 0, then you have to talk about maybe doing treatment without it.
Okay.
I have a question that I have to ask Dennis and Geoffrey N. I just lost Bob McHugh. He was on my list. I'll maybe if Rick could send me his phone number or email, I'll just write to Bob and ask him, make sure he didn't have anything really pressing going on. So Dennis and Geoffrey, can you stay a little late, or would you like to come back Monday, or do you have anything pressing that we really want to get to today? I don't want to leave anybody out.
I can stay if you can.
Okay.
Yeah, we can stay. And Geoffrey, we can definitely stay for you if you're still with us, right?
I am.
Yeah, I see his
Yeah, we can
picture.
definitely stay for you, Geoffrey.
All right, let's go, Dennis.
So hold on a second. Let's just finish up. Let's just close out. Jeremy, so are you sort of good in
I'm
where to
clear.
go next?
I'm gonna see Reddick.
Go see Reddick, and
And
you
he's
know,
got access to all the records since it's part of the UC
yeah,
system. So
yeah, and
okay.
they've got very good. They've got excellent radiation oncologists. Kishan is there. He's one of the best in the country. They've got great equipment. So you know, and if you want to see anybody else, we'd probably suggest you. If you want to see a radiation oncologist, I would suggest Kishan there, Kishan. And we can connect you to somebody who knows Kishan pretty well. Dr. Mark, who is the lead moderator for our low intermediate. But start with Reddick, make an appointment with Reddick, and bear Dr. Kishan in mind, and come back and talk to us, and we'll help you.
And with Reddick,
Okay.
When you talk to his PA, because that's who you're going to get first, be sure and tell her that, you know, AnCan referred you because he knows AnCan well, and she'll take your story to him, and then he decides whether he'll take you on as a new patient.
Okay. Thank you so much.
Yeah, tell him Herb sent you. Okay. you tell him Herb sent you, and AnCan and PCRI, and he'll see you.
Yeah.
Otherwise, we'll be after him. Okay.
Okay. Thank you, guys.
Okay.
Thank you.
Who let's see, it was Dennis I called. Okay, Dennis.
Yeah, a couple of things. I was reading an article, Medscape, the most exciting time for testosterone. I don't know if anybody else has seen it. Rachel Rubin, who I know you guys think a lot of and so forth, was involved in this article and had to do with primarily the Traverse trial and some conclusions from a very large sampling of people, 5,200 men, is that they're having a different feeling now about testosterone being a promoter of prostate cancer. And they did not see this in a large group of men that received testosterone gel supplementation, where we used to think that, you know, that was fuel for the fire, so to speak. You probably heard that. And they're claiming no more as a result of the people that got this supplementation and had no effect on their PSA, their prostate. And there's the benefits, a lot of the benefits from testosterone, the normal ones, but it also helps with the decline in the fat deposition that we all get with the ADT without lowering our testosterone, and our energy, of course, goes down. So if any one of the brain trust people can take a quick look at that, and am I wrong in my assumptions from reading that? Or it seems like 180 degrees from where we've always been about testosterone in the treatment for the cancer
What was the
primarily.
name of the study again, Dennis?
What's that? Medscape.
You gave a name of.
The name, Rachel
Yeah.
Rubin was.
Well, I know Rachel Rubin, but I just looked her up and I didn't get it. Name of the study, maybe?
The Traverse trial.
Perverse?
Traverse, yeah, like traversing a slope, you know.
It sounds like her to me.
No. You're not hearing it right. I think he's saying traverse.
Traverse.
Oh, Traverse. Okay.
So I
I
haven't
thought it was
seen
Rachel
this.
having a joke.
I haven't seen it. Rachel doesn't usually get involved in prostate cancer at all. So
She does the sexual treatment stuff. But she
right.
worked with another doctor there, this Mohit Khera, Khera.
Yeah, it's not ringing a bell with us. So we need to look at the study, and if you can send the study to us, we'll take a look at it. It's not ringing a bell, and I'm happy to reach out to Rachel and ask her if there's something we don't understand. As far as testosterone supplementation is concerned, I think you might be getting your wires crossed a little bit. Where they've done a lot of study now is people who have had treatment and not recurrence. So this study may be looking at using testosterone supplementation after somebody has had radiation or surgery and they haven't recurred. And that's a whole different ball game to talking about men who are on ADT who are and testosterone supplementation. Did you see that in the article? Did the article talk about advanced cancer and ADT?
No.
No.
But
So
I'll send it to you, Rick.
Right. So
where was the study published? Is this the JAMA? Was in JAMA?
Well, I don't know where the study was. I get these Medscape stuff for prostate cancer, and that's where this article came from. And they referred to the Traverse trial.
Okay.
And there's still more work being done. I guess it's not a final thing, but there was some
right.
Pretty.
I think that we really have to be a little careful. I haven't seen this in Medscape Today yet. It'll tell you in that Medscape Today article where the article was published, because they only generally report on articles that are published. So it'll tell you if it was in JAMA or JCO or where it was.
New England Journal of Medicine.
Okay, it was within NEJM, which means that unless some kind person like Dr. Jeff prints it out for us, we can't get to NEJM. But that said, we'll take a look. But my guess is, especially if Rachel's involved, this is for men with low testosterone who have been diagnosed with prostate cancer. And it's not about men like ourselves who are wrestling with recurrent and advanced prostate cancer.
Well, I would just like somebody else to give me some real good.
Yeah, we'll see what we can make of it. Let me go on to Geoffrey now, okay?
Oh, can I get one last quick question for Rick? In your announcement for the meeting, you referenced a 16-minute video, Dr. P. I clicked on that and tried to look at that, and it required a login.
Shouldn't do. Well, or if it's the View Medi, the article on the heart.
Yes.
Okay, I don't have a. Go ahead.
I think ViewMed does require a login, but it's okay. You can just give them your information, and
yeah,
you don't have to pay for it or anything like that.
I don't know.
It requ-
Why I don't have a password or login for wherever that's coming from. I'm not sure where.
You have
What
to
the,
register. You register with ViewMedi.
Yeah.
okay.
Okay, when you
They
go
ask
to that,
Okay.
they ask about what medical profession you're in and want to know all details about your what department you're in, which company, which medical center you're at. It gets quite detailed about who you are. It doesn't have any option for people who are non-medical professionals.
I don't know how I got onto it. It might have been because I went to GU ASCO and so they had me on the list from GU ASCO. Dr. John, do you know about that?
I don't know, but either you or me can maybe get it and send it to Dennis in an email.
Well, the only thing we can send them is the link.
No, not the whole article.
There's no
Let me try.
article.
A
Let me
video.
try, Dennis.
It's not an article. I think what did you eventually get on, Jeff Marchi? Did you see the
No, I didn't want to go through all of them. They came up with a page where they wanted to know a whole bunch of information about your medical experience or where, what department what division you were in, and it was it was just too overwhelming to read the article.
The reason I asked is I'm scheduled in July to see my cardiologist because I've been on this ADT so long and so forth, and with the potential for heart effects. I had a baseline with him a few years back when I got started with all this stuff. So
Okay. So all he's saying, what the Polish doctor, the doctor with the Polish name, Previslav Twardowski, is saying is that we don't seem to think that there's much difference between the agonists and the antagonists anymore. The trials that were done were not accurately reported. So that's what the bottom line is on there, which is what I say in the reminder. I will be more attentive in referring those ViewMedi if they're not available to everybody. But
and I do appreciate the stuff you put in those letters. John and Rick and Len and everybody that does that. It's extremely helpful to me and improving my knowledge about all of this stuff. So I do read that stuff.
Okay, so if it's too difficult, I mean, there's nothing more to take out of it other than the fact that yes, we know that the ADT meds have CVD, cardiovascular impacts, number one, and number two, probably doesn't make much difference if you're on an agonist or an antagonist. We thought it did, but now it doesn't seem to make that difference. Okay, so that shouldn't really affect you. I mean, one of the things it says to me is let's be focusing on monotherapy and see if we can live with monotherapy, abiraterone or Nubeqa or whatever it is that you're on. What are you on now, Dennis?
Abby. I'm on the Abby at the second line, but I'm also getting Lupron or Elegant.
Right. So have the discussion. Let's try abiraterone monotherapy.
Yeah, I was hoping to do when I come. I'm on vacation with it right now. I'm on drug holiday, and I'll do. I'm looking at darolutamide when I have to go back.
Okay, well then darolutamide monotherapy, which is what Len's been on. The issue is not the second line anti-androgen. The issue is the dropping the ADT and just trying to manage with just the second line drug. Does that make sense?
Yeah. Yeah. Well, if necessary, I'll do the Orgovix also with it. Orgovix darolutamide.
Yeah, but the point is that the Orgovix is just as bad as the Lupron or the Firmagon. It's the ADT drug you want to stop. Are you following me?
Okay.
You're saying okay, but are
Okay.
you
On
following?
the ADT would be the Lupron or the Eligard, right?
Or the Orgovix? Orgovix is the same as Lupron or Eligard or Firmagon or all of them. The only difference is it works better, but it's doing the same thing. It's blocking your testosterone. It's stopping your testosterone.
Mm-hmm.
Okay.
Okay.
So in other words, you've got two lines of therapy here. The first line of therapy is stop the testosterone, and that's what these LHRH drugs or GnRH drugs do. They stop the testosterone at the level of your testicles. And when you stop the testosterone, that's when we have these issues around cardiovascular disease and metabolic syndrome. So whatever you use to stop the testosterone, you're still going to have the metabolic side effects. Now, the second line anti-androgen, which is the abiraterone or the enzalutamide or the apalutamide or the darolutamide, they don't stop the abiraterone kind of stops your testosterone. But the other three don't stop your testosterone at all. So you can have high levels of testosterone. They are working in a different way. So monotherapy darolutamide will allow you to have testosterone in your body. So the issue is, what about monotherapy? And I don't know monotherapy abiraterone, Ken tried that years ago, and he was on it for a long time. I don't know. Would monotherapy abiraterone reduce your testosterone to 0, John?
Not your blood test. Oh, well, yeah, maybe it would. I mean, theoretically, maybe it would. If the enzyme is blocked, you can't make testosterone. Yeah, it should.
It should. So, maybe the abiraterone is still going to have a cardiovascular effect, but the ones that end in "ide" are not.
Yeah.
So we still got Geoffrey Nourse, and I also see that that Jeremy put something in the chat window that he can't get to see Rettig because he doesn't have Mets. So my recommendation to Jeremy is go see Dr. Kishan. He's not there right now. He stepped away. Let's go to. Should we go? Can we move on, Dennis?
Yeah. Fine. Thank you.
Let's go to Geoffrey Nourse, and then we'll finish up with Jeremy when he comes back. You had a bunch of names in there. Larry Fish is still with us. He can talk to you about Dr. Audio. If it were me and I was trying to get in to see somebody at MSKCC, I probably would go to Dana Rathkopf.
Yeah, if you can, definitely.
I think Larry, you like Dr. Audio, right?
I do. I get along very well with her. But, she's very easy to talk to.
Okay.
Is she the best doctor I can imagine? Perhaps not the very best. But she works with Rathkopf, and they work on.
Right, and we like Dana Rathkopf a lot. She's really good. You can't get in anymore to see Morris or Cher. I would say Morris, if you could get in to see him, would be the number one choice. Second choice for us would probably be Dana Rathkopf right now.
Yeah,
I would not.
We're still working on Morris. We have a contact, so I don't think it's going to happen. So Dana, what was Dana's last name?
Rathkopf, Rathkopf.
Okay, great, fantastic.
She knows AnCan very, very well. And we've got Ben Nathanson is actually with her, right? It's his doc right now. And I'm sure she'd see you. If she doesn't, let us know, and we can pull the strings there. I don't know.
I'll probably just go in and see Karen first, and we can have the conversation then.
No, don't do that, because you won't be able to switch.
Okay.
Okay. If you go to audio, that's who you're going to be seeing, and it's very difficult to switch doctors at Memorial Sloan Kettering.
Okay.
Okay, so if you go see audio, you got audio. All right.
Fair enough.
If you think you can get to Morris, don't go to Rathkopf until they say no, you can't see Morris.
Okay.
But it's very, very hard to switch docs at Memorial Sloan Kettering.
Yeah. So my kind of conundrum right now is that what I have is incredibly aggressive. My PSA shot through the roof. I'm 9. I'm a +4, +5, metastasized, multiple organs, bones, everything. So I'm new to this, right? This is 3 weeks in, and I just don't know how to judge what doctors have experienced. So that's why I put Quan in. Quan had some videos talking about being more aggressive with prostate cancer, much like with
Quan. Forget Quan. Okay. If you come into this group and you start talking to us about Quan, we're going to squash you. All right.
Okay.
No, I'm serious. We've done it before, and we've had people get upset with us. We've got a Quan guy who's not on today. Dr. Quan is a urologist.
Okay.
All right. He's not a GU medical oncologist. He's a wannabe GU medical oncologist.
Well, that's the end of it right there.
And he is stuck on certain older methods, which he doesn't want to give up. And, he's still using C11 when PSMA scans are out there. He doesn't collaborate.
Okay, fair enough.
Which is a real problem.
Yeah, if he's not a GU med oncologist, then he's off the list right there. So that's cool.
If you want a GU medical oncologist at Rochester, Oliver Sartor. Sartor.
Yeah, I wasn't going to go to, yeah.
But
okay.
I would say this, because you're going to make yourself nuts. You don't have to go, you don't have to see 4 or 5. If you start with 2. That would be my advice. Start with 2 really good ones, and go from there.
The challenge is I don't know who's really good, right? So I've got Dr. Corbin Eule, who's here in Denver, who's got rave reviews in Denver, but Denver's a small market, right? Nobody knows this guy.
I don't know him. I thought you were going to see the other guy there who runs the lab. What's his name?
Yeah, I don't remember, but no, we can't get into them at all.
Okay, so don't bother with Denver. Okay,
well, my thought is that if I'm getting treatment from MSK or Dana-Farber, does that mean I have to fly every time, or would it be better to have the procedures here and have the treatment dictated by somebody more advanced?
So whoever is your key doctor, your quarterback doctor, ask them to help you find, because they'll direct you to somebody they can work with in your market.
Perfect. Okay.
Right.
So how about Surzan? Does anybody work with Surzan out of Dana-Farber?
No, I know a lot of people. We know a lot of people at Dana-Farber. We have some on our advisory board, but we don't. But Surzan is not one I know.
Okay.
I mean, I can give you names at Dana-Farber. if you, the one doctor who isn't on your list, who I would send you down to, especially since it's aggressive and you're young, is Eleni Evstathiou. And I think that you'd get on great with her. She's very aggressive. She can work with everybody. She's super smart. And there are people on this call right now who see her, at least 2 or 3. She is a fantastic doc. She was 14 years at MD Anderson until 2 years ago. And she left MD Anderson for various political reasons. And she went next door and started up her own GU practice at Houston Methodist. And
okay,
she would definitely be one of my doctors. Maybe Dr. Radkoff. Maybe if you want to go out to the West Coast, I can give you 3 names off the top of my head on the West Coast.
we're on the West Coast, LA area.
San Francisco, LA, or San Diego. I can give you names. I can give you 3 names of fantastic GU medoncs in all 3 places.
So this is really where the conundrum is, Rick, right? So the challenge here is that we have a lot of people with a lot of experience with a lot of doctors, and some are great, some are good, some are sufficient. I have no way to judge who I should set up appointments with, right? All I have is I've been told these facilities, MD, MSK, Dana-Farber, Mayo, that they're the best in terms of having a team and having a variety of different programming available. So I don't know George from Jenny at any of these facilities.
I understand. So then you would have to sort of trust what the guidance that we're giving you. And I would say Eleni, Dr. E is great.
Okay.
I really think she's terrific, and she worked with a lot of different places. She's super smart. I would say I'm conflicted about Memorial Sloan Kettering, to be honest.
Okay. Fair enough.
Only because it's a little bureaucratic, and I don't know. I mean, Larry's still there. I mean, Larry really could talk to that, but sometimes it's hard to sort of to move between places, and they have things they do and they have things they don't do. They don't like Provenge, so they're not going to give you Provenge, but they like this and they like that. I don't know. I mean, if it were me, I would probably see for you.
Let me give you just a little bit more background, right? So I'm 59 years old.
No, I have your background. You gave it to us last time, Jeff.
Yeah, right. But I'm also a nationally ranked athlete in multiple sports. I mean, I am super fit, amazingly fit. So I want to fight this. I want to win.
Okay. Go see
Dr.
I
want a doctor that wants to be on board with that. That's going to say, look, tell me what to do. I am going to do it. It's going to happen.
Okay.
So,
go see Dr. E. I'd also suggest to you, for you, because she works with a lot of younger guys. I know this for a fact. I'm not sure how well she knows us. I think she does. Rana Mackay at UCSD, UC San Diego would be a very good choice for you. And she's right on the cutting edge. So Rana Mackay at UCSD, Eleni Evstathiou, and if you wanted somebody on the East Coast,
it doesn't matter if it's East or West. I just want the best. I don't care where.
Well, the names we're giving you they're all really good.
Fantastic. So I've got Elena, I've got Rana, I've got Dana Rathkops. So
Dana Rathkopf. Shmulewicz is pretty good, and the guys seem to like him, and he really listens to them. He's in the University of Chicago.
Who's that?
I think I gave you Eleni Evstathiou last time. If not, I can I can, there's her name because it's hard to spell.
No worries.
Actually, Rick, and we already put within the chat by someone.
Okay.
Okay.
Already in the chat.
Okay. Sartor. Sartor. That's probably, if I was looking for a third guy, he's aggressive. He's a little. He's not as down to earth. He's a little more pompous. Pompous is maybe not the right word, but and he knows us real well. He just did a webinar for us earlier this year. But Sartor's a very good option at Rochester.
Well, this is fantastic. This is exactly what I came here for. To get the kind of feedback and insight into how I make these initial decisions. Because you're right, I don't want to be jumping around, and I don't think I can get what I need in Denver. So yeah, this is great.
Okay, it's Sartor. Oliver Sartor. We can pretty much tell you can't because we've had people from Denver before. And and the guy who ran the lab was a new name to me, even though he's been there forever, because I guess he doesn't see patients. I don't know I was surprised. I was hoping you were going to see him so we could get some feedback on him.
Yeah, I'll see him on Thursday. I'm going to see Eule, E-U-L-E. They pronounce it Eule. I'm going to see him on Thursday.
Okay, well, I don't know from him, but for me, Eleni Evstathia, Julian sees Eleni, Joel Blanchette sees Eleni, and I don't know, we've probably lost the other. Somebody else sees Eleni too.
Sounds good.
But she's. Do either of you? I gave Larry Fish to speak up on audio. Would either Joel or Julian want to say anything about Dr. Eleni?
She's very thorough and very personable. You better have your notes ready.
Already have my entire chart on a flash drive. Goes with me everywhere.
I think
I'm a former engineer, so I'm extremely organized and very thorough.
I'll tell you a quick story. I went in there with a bunch of notes. She looked at the notes. She looked at me, looked at the notes, and said, "You're an engineer, aren't you?" I said, "Damn."
Yep.
General, what do you want to say about Eleni, Dr. E?
Yeah, she's very sharp, very, very, very sharp, and she will work with you at anything you want to do. But if you follow her direction, she will delay your prostate cancer or even cure it. She's very smart. She goes around the world and lectures other doctors around the world on prostate cancer. She's not anybody to be dismissed.
You'll find her. You'll find her on our advisory board. If you look at our advisory board, you'll find her on there, Geoffrey. It's hard. So much of it, I truly believe we can only tell you how smart these docs are. And all these docs that we're mentioning, we talked about Dr. Reddick. He's great at UCLA. I can give you a guy, Rahul Agarwal at UCSF. I mean, or other doctors there. But it's how you relate to them. So much of this is about, with a serious disease like this, it's about how you and they mesh. And we have some doctors, I find certain doctors, there's a doctor, there's a very well-known doctor at Memorial Sloan Kettering, and we've got people that love her. Some in this group, I find her cold and removed, and she's a very good doctor. She's a very good doctor. There's another doctor like that at Dana-Farber, but she's a great doctor. I wouldn't want to see her. Mackay, by the way, Rana Mackay is RANAMCKAY. Okay, RANAMCKAY. And again, I've got younger guys who are seeing her right now. And if any problems, we can go through them. But These are the doctors. Try and find videos of these doctors and see how they come across to you, okay?
Absolutely.
Dr. Sartor did a webinar for us in January on PSMA. Go watch that video. See how he comes across to you, okay?
Sounds great.
And then come back and talk to us some more.
Absolutely. This has been wonderful. So I dialed in on the 11th, and that was 6 days after my diagnosis. And 2 weeks later, I'm on my 4th day of Orgovyx and going to be starting up Nubeqa. But I wanted to wait to do those things until I found a GU medical oncologist, because I don't have one right now. So,
well, again, there's a lot with sequencing. I mean, there's a good argument to do abiraterone before Nubeqa.
Right.
Because we know that abiraterone that abiraterone following Nubeqa is probably not going to do that much for you, but at the same time, there's about 8 to 10% of men who do it the other way around, and we see a better response when Nubeqa follows abiraterone. So you've got to decide which one you want to do first, or your doctor has, which one they want to put you on first. Now, the trade-off is quality of life, because the darolutamide is going to give you better quality of life.
Yeah. Well, this has been great. Thank you so much for all the feedback and all the insights. This is
a
wonderful.
Pleasure. And Jeremy, I got one word for you. Turn on your camera and turn on your mic. Are you there, Jeremy? He was just there and now he's not there. All right, well, I'll hang on until he comes back. Oh, there you are. Dr. Kishan, make an appointment with Dr. Kishan. You're muted. Unmute.
Right. He's a radiologist, though. Right?
Well, if you want to go to, he is, but if you want to go to UCLA,
yeah.
I mean, your buddy at City of Hope, was he going to set you up with a rad-onc or with a GU med-onc?
I don't know. I have no idea.
See, here's the problem. I know what problem you're having. The problem with some of these GU med-oncs is they don't want to see you until you have a confirmed metastasis.
Right.
Right? And that's the problem you're having with retic. Yeah. Now, if you had a lesion, he'd see you, but he doesn't want to see you until that lesion comes. So that's why I'm saying go see Kishan, and then when we figure out what's going on, you can slide over to retic.
Okay.
That's why I'm saying it. And Kishan is really good.
Yeah.
Okay.
You sent my friend Brandon Neil Brandon over there.
Oh, yeah. Did you send Neil to me?
Yes, I did.
Oh my gosh. Thank you.
Yeah.
Have a great, There aren't that many people like it. The only problem with Neil, you tell him when you see him, is that he's a Spurs supporter. Other than that, he's a terrific guy. Just tell him. That's what Rick says. That's the only problem. He's a Spurs supporter. But seriously, go see Kishan. I'll tell you what I'll do. I will. I'll have you talk to Dr. Mark Perlow. Okay.
Okay.
I'll send you still the same. What have I got for you?
Denim blue. Yeah. That's it.
All right. I'll send a note to you and Dr. Mark afterwards. Mark lives in Sherman Oaks. Okay. So I'll send you a note, and he knows Kishan really well. Let's get you to Kishan, even though he's not, because then I know we can slide you over to retic.
Okay.
We got you back.
Okay.
Can I ask who told you can't see him?
The front desk. I got a woman, and she
Yeah.
wanted to know, and she actually went into my file because it's at UCI and the UC system, and she saw the PET scan had come back negative for any Mets throughout the body, and the PSA was still very low, 0.16. And she
So,
said she plugged it into a formula and
yeah.
nobody came up. And she said the only person who can see is Keyshawn.
Well, let me just give you a little quick anecdote. I was unhappy with the care I was getting. Uh, I contacted Memorial Sloan Kettering, and I got the same answer you did. Well, your PSA is low. It's not rising. You don't have Mets, so you can't even come here to Sloan Kettering. And
Wow.
okay, but this was like you, someone at the front desk.
Yeah.
So I did a little research and I got a hold of a provider PA, and I pleaded my case over the phone to the PA, and they said, let me talk to the doctor. And next day, doctor will see you. You can come here. We'll accept you. You can be a patient. So I'm not sure I would take the final word from some clerk at a front desk, telling you can't do it. I would try to speak to a medical person and tell them what's going on, and they may change their mind. They did for me.
Yeah. The only thing I'd say, Dr. Jeff, and you're right, you're absolutely right. I don't disagree with you at all. But if you can get to Kishan, then you've got to try and figure out, you don't want your care to stay with Kishan in the long term, because the Radonks, they also want to play medical oncologist, right? But Kishan is a terrific person to try and figure out where the metastasis is. By the way, I mean, we had a very similar problem at City of Hope, but with bladder cancer. Had a guy with bladder cancer, and we couldn't get a medical oncologist to see him because they hadn't identified exactly where the metastasis was in the bladder cancer. And then eventually, when we did it, then he moved on. So my feeling, look, I can also connect you with Herb Courtney. And he can send a note to Dr. Rettig and say, this is a guy in my group. I'd really like you to see him. And he may do it, but he's probably going to finish up sending you back to Kishan until they figure out where it is.
Right.
Right. And, when you're ready, you can say to Dr. Kishan, when he's found it out, and that you're talking about how do we treat it and what sort of hormone therapy, that's when you say to him, well, I'd like Dr. Rettig involved.
So no thoughts on UCI and Uchio over there?
I really don't know enough people at UCI. There is one, I ran across one medonc who's there, GU medonc. Where do you live, by? I can't remember. Are you?
I literally live right next to the university in Anaheim near Disneyland.
Oh yeah, so you are down there. I can't give you a name. There's one person at UCI whose name came up recently on something I watched, but I really don't know them. I don't know anybody who's been treated by them. Who's the person? Who's the medonc the GU medonc that you'd like to see there? Or you're thinking?
I don't know yet. I haven't. I just got sort of a blanket response to when the PET scan or the PSMA scan came back negative. There was a note that said recommend multiphasic MRI because of artifact or too much activity in the bladder, and that the PSMA may not be able to see whatever might be in there. And then so I sent a note, and I just got a note that said the MRI isn't necessary. We'll see you on July 2nd. That was it.
I I think Kishan is probably a real good guy for you, and talk to Dr. Mark about that. But I think that Kishan might be a really good starting point for you. And then when we find out and we're talking
Like you
about
said, Rick, we
treatment,
got to figure out why the PSA is ticking up.
that's right. And
Okay.
I think that Kishan is probably pretty good for that.
Okay.
Rick,
all right,
can there be, after a radical prostatectomy, some leftover prostate, small amount of prostate tissue that could be making this now and not be a metastasis?
There could be, but it would usually show up much, much sooner. It wouldn't show up 2 or 3 years later. It's not like it's not like a radiated tissue where it there can be a flare down the road. If there was tissue left, then most likely it would have shown immediately afterwards.
Right, like in Neil's case. Yeah, exactly.
Yes, like in Neil's case, exactly.
Yes, yeah.
It would have shown right away. So the likelihood is that there's something there, but we just don't know where it is. We can't see it. I mean, we've got other people dealing with a similar issue right now.
Yeah.
So
I'll go to Kishan.
I would, if I couldn't get in, and I was stretching, would I go to see Tanya Dorf or would I go to see Kishan? Probably Kishan, because I don't know the radoncs that well. I do know Kishan's a fantastic radiation oncologist, and he's got at least one really good medical oncologist that works with him that you can easily get referred to.
And he was the earliest, August. Everybody else was October.
Yeah, go see Kishan. And then when you go him, you can drop Mark Perlow's name. I'll connect you to Mark Perlow, and he'll treat you right.
Okay.
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 All right, guys, I got to run over to a webinar on pancreatic cancer now. So it started 10 minutes ago.
Thank you so much. Thank you.
To John even? We lost Dr. John. Good night, everybody.